Hello, and welcome to the Hearsay podcast, a joint project between Pro Bono Students Canada, University of Calgary Chapter, and CJSW 90.9 FM. This is a podcast where University of Calgary law students discuss a variety of legal topics with a plethora of professionals in the field. We'd like to emphasize that the information you hear today is legal information and not legal advice, as we are law students and not lawyers. This podcast is purely for informational purposes. If you do require legal advice, please consult a lawyer, as there is no substitute for a professional. We have 3 hosts today. My name is Sean, and I'm joined by my co-hosts Matt and Carson. Today we will be speaking about artificial intelligence and health law with Professor Lorian Hardcastle. Lorian Hardcastle is an assistant professor in the Faculty of Law at the University of Calgary with a joint appointment to the Department of Community Health Sciences in the Cummings School of Medicine. She is also a member of the One Health Consortium, O'Brien Institute of Public Health, and Conjoint Health Research Ethics Board at the University of Calgary. Lorian obtained her JD with Health Law and Policy Specialization Certificate from Dalhousie University and her LLM and SJD from the University of Toronto. She also completed a fellowship at the O'Neill Institute for National and Global Health Law at Georgetown University Law Center. This is the first part of a 2-part program addressing the intersection of artificial intelligence and health law. The development and application of technology is critical for improving the quality of healthcare services and improving health outcomes. Artificial intelligence is at the forefront of technological advancement and is already beginning to make a major impact on healthcare. The use of AI tools offers potential solutions to some of the greatest challenges that healthcare faces. It has the potential to address issues such as improving access to healthcare for rural communities, increased access to remote care, improved diagnostic tools, and streamlining of administrative tasks. And this is just the beginning. However, it also comes with significant challenges that lawmakers must address. Legislation will be needed to address potential liability attributable to AI error. The massive quantity of data required to develop these tools creates significant privacy concerns. And the use of data sets that are not representative of minority groups may lead to biased algorithms. We hope these episodes can provide an introduction into this area and the challenges that must be considered. In the spirit of reconciliation, we would first like to acknowledge that Hearsay is recorded on Treaty 7 territory. We would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The City of Calgary is also home to Métis Nation of Alberta Districts 5 and 6. I would also like to note that the University of Calgary is situated on land adjacent to where the Bow River meets the Elbow River, and that the traditional Blackfoot name of this place is Mackinsis, which we now call the City of Calgary.
Thank you for joining us, Professor Hardcastle. Would you mind just taking a moment to provide us with a bit of background and summary of your academic and professional credentials?
Sure. So I have a JD with a health law and policy specialization. I did grad work in health law. I practiced for a little while in health law. And so my research really focuses on health law issues around patient safety in the law, artificial intelligence and its use in health, quality of care and hospital liability issues, governmental the role of government in the health sector, accountability, finance, and then, of course, over COVID-19, I did a fair bit of work in public health law.
And how did you become interested in topics such as healthcare law and the intersection of healthcare law and artificial intelligence?
Yeah, so certainly I've always been interested in health law and went into law school knowing I wanted to do that area. And I think with respect to issues like artificial intelligence or patient safety, what I had seen was trends happening in the health policy literature or new developments in health technology. And then, of course, it begs the question, is law keeping pace with these new developments? Does the law reflect what we're seeing in the medical literature, the health policy literature, or is law a barrier to some of the changes that we would want to see?
And are you currently performing or planning any research regarding the use of AI or just in general other technologies in the healthcare settings?
Yeah, so certainly it's a project I've been involved with for a few years that looks at the use of AI in health, and I don't think that project's going away anytime soon. I've also done some work around new reproductive technologies and the law, and so law and tech is something that you really can't get away from in the health space. And then, of course, there's also pharmaceutical law where there's always new developments there as well. So you kind of have to keep pace with what's going on in the health sector in order to keep your research relevant.
And then just a bit of a broad overview question here. What do you see as the current state of the field regarding AI and health law? Any specific directions things are moving?
Well, I think right now, one of the big things that we're having to sort out is how do we regulate AI? It's not like a typical medical device that's very static, like a stethoscope or a thermometer, where it gets approved by Health Canada and stays in its current state. One of the interesting things is how do we regulate an algorithm? Because, of course, it's constantly evolving. And then the other big issue is who should be responsible? Right now, the decision-making lies primarily in the hands of the health professionals. But if we have this proprietary technology that's indicating that a patient should be given a particular diagnosis or treatment, will we then shift away from responsibility lying with the health professional and responsibility being more on the device manufacturers? So will we see more product liability?
And leewaying off of that, we noticed that much of the existing literature examining these subjects has discussed issues such as privacy, bias, and liability. Could you highlight what your top concerns or set of concerns within this field would be and elaborate on why those concerns are at the top of your list?
Yeah, I think those are fair concerns around privacy issues. As soon as we get into using big data, we can certainly run into privacy issues. And I think that some of the health privacy statutes are quite dated. Some of the privacy laws we had around Canada were put in place when we were still using paper records. And so that's not only an AI issue, but an issue in general. As we shift to using online virtual clinics and those sorts of things, the privacy issues also arise. With respect to the bias issue, of course, algorithms are only as good as what you put into them. And so certainly there can be disparate impacts or inequity if we're using algorithms that were designed using a particular patient population and we're extrapolating them to others. And so you can imagine, for example, an app that's designed to detect skin cancer, if it's primarily being tested in Europe, and then we're using it in North America on Indigenous populations or on Black populations, is it going to be as accurate for them, or are they going to be getting a different standard of care? And then with respect to the liability issues, a lot of that is really just who will be liable for these technologies. Is it the professional using them? And if the professional is relying on this technology, is it reasonable to rely on the technology? Or if their diagnosis would be different than what the algorithm is spitting out, what are they supposed to do with that? So if their instinct is that this mole is not cancerous, but the algorithm is saying it is, and they know that the algorithm regularly outperforms physicians, what do they do with that information?
And on the other note, there's definitely a lot of upside to the use of AI in healthcare. What would you say you are most optimistic about when it comes to the prospects of the use of AI in healthcare settings?
Yeah. So there are certainly areas where AI can outperform physicians, where there is a fair bit of discretion or cases on the margins, and we use guesswork sometimes, or try and use experience, those sorts of things. But technology can in certain circumstances outperform humans for certain tasks. And then I also wonder about the use of AI with respect to wait times. So, for example, if someone comes into the hospital, to the emergency room, and it's potentially going to be a long wait and has certain symptoms, can we, before they even see the doctor, have them have already had some of the appropriate diagnostic tests, blood tests run, so that by the time they see the doctor, some of that's already happened, and it's a more efficient use of that doctor's time. And then I guess a third application of technology, maybe not so much AI, but technology in health is just we have physicians concentrated in urban areas, and we have rather poor rural access. And so just the use of technology to try to bring physicians to some of those rural and remote areas.
And a big concern in developing these tools is striking a balance. So we want to balance the concerns of minimizing medical errors while still promoting the development of AI tools in healthcare settings. And there's a risk that if we are too strictly controlling the development of tools, it will stifle the efforts at advancing the technology. Do you have any thoughts about this, the approach to balancing between innovation and preventing error?
Yeah, that's not only an issue with AI, but really across the health sector. It's an issue with pharmaceuticals. We saw that push and pull with the COVID vaccine. So how quickly do we roll them out versus how rigorous are we on the regulatory approval? We see these issues arise with respect to new reproductive technologies. And so do we roll out these technologies or do we regulate? And Canada, that's an area where Canada has lagged behind. And so there's always going to be this tension, but I do think regulators have to try to strike that balance between trying to keep quality high and trying to ensure access, but also responding to some of those concerns and making sure that those concerns are addressed, or there's a plan to address them or monitor them as the technology is rolled out.
And as far as regulation goes, we know that in Canada there are several different areas which regulation comes from. The regulation and oversight of healthcare is primarily a responsibility of the provincial government. There is federal funding that plays a significant role, and in addition, there are professional bodies that provide oversight and self-regulation. In their current form, do you think these different entities are capable of handling these rapid advancements, or do you think they need to be a little bit reimagined and redesigned to deal with these new challenges?
Well, I think there's always been a tension in health between the provinces and the federal government. And, we've seen this play out over and over again. And it's particularly acute right now in Alberta, where there are these tensions between the province and the federal government and a lot of pushback by the province. For example, the federal government recently announced the expansion of pharmacare, and Alberta indicated it won't sign on to that. Every year when the Canada Health Act transfer payments are announced, there's always tension over the amount, and money gets held back from the provinces for allowing privatization. So there's always those tensions. But I think with respect to which level of government is doing what, some of it is historical. So, for example, hospitals are constitutionally allocated to the provinces. But then, of course, there is an interest in having the federal government have a role as well, because they are able, through their finances, to advance things like pharmacare or universal dental care.
On that note, do you see the federal government potentially regulating how the funding granted to provinces is spent in relation to AI health?
So specifically in the area of AI, the federal government doesn't tend to earmark funds specifically for that. Health Canada does have a role in regulating medical devices and new technologies. So Health Canada is certainly involved in regulating that. But with respect to the funding piece, the provinces really decide what technologies are adopted and how those are funded. And some of those decisions even happen at the hospital level or the regional level. And so they tend to play two pretty different roles. But with respect to federal conditions on funding generally, that's always been an area of controversy. The federal government attaches strings to money under the Canada Health Act. But there's always been a push and pull there with respect to how many conditions they have and how vigorously those conditions are enforced. And the reason for that is it's partly political and those tensions that we see between the two levels of government, but it's also historical. The federal government used to pay a much larger share of provincial health expenditures than it does now. And so as that federal portion of funding went down, the provinces pushed back harder and harder against stringent federal conditions.
You mentioned previously that the AI is often based on machine learning algorithms, and that these are constantly changing, and they're also proprietary and commercially sensitive. How will this impact the ability of regulators to validate the machine learning algorithms and ensure that they actually do what we're being told they do?
And that's something Health Canada is struggling through right now or working through right now, is how to regulate given the proprietary nature of the algorithms. Of course, they do regulate other areas with proprietary information. So, for example, pharmaceutical data, those sorts of things. So that's an area they've worked in before. I think the bigger challenge is the idea that it's constantly evolving. And there have long been conversations about health medication or how medical devices or health technologies have been regulated in a way that is too focused on they get approved and that's the end of the federal government's role. And Health Canada has long been criticized for not continuing to play an oversight role unless something goes very wrong. Over the past few years, they have ramped up their oversight of drugs and medical devices after they get approval. And so the idea that they would constantly be evaluating the performance of an algorithm and the way it changes over time as more data is fed into it is maybe more in line with this approach that they've adopted in more recent years.
You're listening to the Hearsay podcast on CJSW 90.9 FM and online.
So, on the topic of professional liability, how will we account for the professionals who are designing the AI tools? What proportion of the liability should be apportioned to them compared to the healthcare professionals who are implementing those tools?
I think it really depends on the situation. And so we do have other examples of this. For example, there are cases where liability has been apportioned between a drug manufacturer and the prescriber. So we do have some precedent for this. But I think that it's going to depend on how much of a role or how much discretion the health professional has. And the more their professional discretion is applied to the situation, the more they potentially bear liability. Whereas if we're talking about an algorithm that is making treatment decisions without the involvement of a professional at all, so let's say you come into the emergency room and AI is being used to triage you or refer you for particular testing or treatments, then to the extent that there's no health professional involved there, liability would fall much more heavily to the device manufacturer.
And somewhat following up on that, do you think that things like citations will be an issue when you're getting information from these large models with multiple sources? Do you think citations could become an issue of where that liability is ultimately lying?
I'm not sure that I understand what you mean by citations.
So if tons of data from various sources are being fed into these large models, and then if they're not providing citations, or I think some will, do you see that potentially being an issue?
Yeah, absolutely. That's an issue because, of course, right now, if you go to your doctor and you ask for a treatment recommendation, they're able to walk you backwards and tell you where that recommendation is coming from. Whereas if it's being churned out by a proprietary algorithm, they aren't able to engage with that information and with the patient and that information in the same way that maybe was historically the case. So if we look at the kind of skin cancer example, it's a very different conversation if a doctor says, well, I'm concerned about this mole, and they're able to explain to you exactly why, the color, the margins, the size, the changes. And that's quite a different conversation than if they simply are only able to say, well, this algorithm performs well, and it's telling me we shouldn't be concerned about this.
Should physicians and other healthcare professionals be required to have a foundational understanding of these tools? Should it become part of their licensing requirements and professional regulation, in your opinion?
Well, I think that the more these tools move out of the research space and into the treatment space, and the more they're used in treatment, it's going to become essential for that to become part of the training process and those to be the sorts of technologies that they read up on if they're being used in the field. But I also think that to the extent that these technologies are being adopted at the hospital or the institutional level, they too have an obligation to train staff in the use of whatever technologies they're using.
Have you seen any pushback from practicing physicians regarding the potential liability that they might be exposed to when having to work alongside and integrate AI into their practices?
Not yet. A lot of these technologies are being used mainly in the research space, and so participants are consent to their use and sort of know what they're getting into. I do wonder if there could be pushback if some of these technologies are being seen to replace clinical judgment. And we saw a similar thing happen in the 1990s when there was this emergence of what was called evidence-based medicine, and there were treatment guidelines and care pathways, and a lot of physicians embraced that because, of course, it was based on the best available evidence. But there were people who pushed back and said, well, my experience is also important, and this is cookbook medicine and those sorts of things. So we could have some people pushing back on a similar basis if they feel like clinical decision-making is being replaced in certain spaces.
And we have touched on this earlier, but how suited do you believe that the current medical device regulation and medical negligence laws are? How suited are they to attend to the possibility of error on the part of AI?
Yeah. I think that the device regulations, Health Canada certainly has seen this coming and is working on this and has been for several years. So I think I have a reasonable amount of confidence that this is on their radar and that they have experts in this space thinking about these issues. And that's not always the case. So, for example, we did a poor job of regulating other kinds of health technology like reproductive technology. We lagged for years and years and years to address that. So I think they've been more on top of this than some other spaces. And I think with respect to the liability issues, tort law is inherently somewhat flexible and has the ability to apportion damages between device manufacturers and physicians. We don't have as well developed an area of products liability as does, say, the U.S. But certainly there are cases where drug manufacturers, device manufacturers have been liable in Canada. So there are those precedents.
And again, touching on a topic you had mentioned earlier, if we're working on the premise that if a data set collected is biased and it targets a particular race, gender, age group, and that's going to create a biased model, are you worried that, or do you think that our current human rights laws and anti-discrimination laws can attend to this? Or if not, do you think that new or different regulations would be needed?
Yeah, I'm not sure that our current laws really do effectively address those issues because, of course, these issues aren't new. Historically, health research has tended to often recruit healthy male participants in a particular age group and has excluded certain groups like women due to concerns that they might become pregnant during the trial. And that, of course, makes the research results less relevant to women. And we also see significant disparities in the quality of care that different groups receive. A lot of ink has been spilled, for example, on the poorer standard of care that Black people often receive in the U.S. There are, of course, similar studies in Canada around the care received by Indigenous people. And so I think that we already have these issues, and it seems clear that existing human rights legislation and the Charter isn't necessarily the most effective tool to get at these problems, which sometimes aren't policy level problems, but rather are more granular problems with clinical decision making. And so, for example, there's a lot of studies showing that African American women have much greater maternal mortality and morbidity. And it's not that there's policy level policies that are being adopted that are causing those things, but rather it's this complicated mix of variables. Some of them are social, some of them are economic, some of them are bias on the part of professionals. But all of that is happening in that treatment context. And so we almost need better training and more conversations around these issues because it's hard to base a human rights complaint around this idea that, well, I received poorer care because this doctor was biased, or because I waited longer in the emergency room because they didn't believe what I was saying, or those sorts of things are hard for human rights law to kind of capture.
This concludes part 1 of our podcast on AI and health law. Thank you, Professor Hardcastle, for taking the time to speak with us today. You're listening to the Hearsay podcast. We are proud to present you with legal information, but please remember that this is legal information, not legal advice. If you require legal advice, please consult a lawyer. The Hearsay podcast is a joint project between CJSW 90.9 FM and Pro Bono Students Canada, University of Calgary chapter. If you would like to hear more podcasts like this, the Hearsay podcast can be found on Google Podcasts, Apple Music, Spotify, or wherever you get your podcasts. Thank you for listening, and we'll see you next time.